So, good morning, everyone. So, I will be talking about this critical appraisal of a precision medicine study. The initial part of the talk, I would like to talk about what exactly is precision medicine. I'm sure all of you would have heard this term floating around, but we may not know exactly what it means. And then, secondly, second part of the study would be how to critically appraise the study that is there. So, again, very commonly we see patients also would have heard this. I think there was 10 years ago, Obama had a speech on precision medicine and how it is the future. And so we would have heard it definitely, precision medicine in ARDS, patients would have also heard it. So what exactly does it mean? So any registrars want to know, want to guess what exactly do you mean by precision medicine? Anything? Yeah, very good. So something similar. So how do you think it's different from precision medicine? Oh, sorry, personalized medicine. So often these terms are quite like used interchangeably. Physicians always treat patients on a personalized level. So can it be actually be used? We always treat patients based on their preferences. So whether these two terms are interchangeable or not is what this we're looking at. So what it's a new modern approach to understanding health. So basically, we have new biomedical info that could be either your clinical data, lifestyle, genetic, biomarkers, all this, and you add it to your conventional system, signs and symptoms, and then you come up with further treatment algorithms and things that you can use. So let's take it with an example. So we have a 25-year-old lady. She has come to you and she's come with breathlessness. You have done a spirometry and you've diagnosed her to have asthma. So do you think she behaves just like any of the other patients with asthma? So there is nearly one person out of 30 individuals, Indians, would have asthma. So do all of them behave the same or would they behave differently is what we're asking about. So we know that asthma is a heterogeneous group of heterogeneous disease, as probably if you have heard in the MAC conference, we discussed about how asthma has different phenotypes. So the traditional approach would be one size fits all approach. So give all of them bronchodilator, see what happens. All of them supposed to work. So it's supposed to be very precise, supposed to fit to the whole population. However, when it comes to precision medicine, we have four different groups. All of them have asthma, but do they all behave differently? They may not. They may behave quite different. So how do we become more precise in what we use? So we use whatever data that we have available to us. So we have lab data, the dietary habits, maybe the environment, how fit they are. All this we incorporate, we connect them, and we kind of analyze them and try to find out, okay, what is the best treatment or how to prevent disease. So we get something like this. So this again another article. So just looking at how asthma can be related to precision medicine. So if you're looking at this medical history and physical examination, age of onset. So children who have a shorter duration of disease and younger children may respond better to Montelukast. Whereas lifestyle, if they are exposed to cats at an early age, they may be more likely to develop atopic eczema. Then we've heard a lot of IL-5 inhibitors. So if they have a very high IL-5 levels, eosinophil count, they may respond better to IL-5. So functional diagnostics. So we talked about FeNO also a few days back. So again, if they have a high FeNO levels, they have a better predictor to ICS. Then comes to the omics, so genomics, metabolic omics, a lot of genetic data that can also be used to choose what would be the ideal treatment. So precision medicine kind of covers how you will respond to the treatment and how people similar to your age group and how your phenotype would respond. Okay. So again, this is another definition by the National Institute of Health. So this is an innovative approach that uses information about an individual's genomic, environmental, and lifestyle information and kind of guides decisions on medical management. So the goal is to be more precise and precise approach to prevention, diagnosis, and treatment of disease. So the main, precision medicine has really boomed in cancer therapy. So for example, in oncology, breast cancer, we know that HER2 new gene. So patients who have that kind of have a worse prognosis. We know that from before. And then over time, we are able to target that gene and we are able to target that protein. And we give trastuzumab using trastuzumab, and we know that patients will have better outcomes with that. So another example, just pictorially demonstrating it. So we have our current medicine, which is a one treatment fits all. So this is patients with colon cancer. All of them may not respond the same. So we give the treatment. Some may have a good effect, some may have no effect, and some may actually have adverse effects. So precision medicine is kind of more of a personalized approach where we have a lot of other data that is there. So we have their DNA, their tissue analysis, mutation analysis, and then we kind of segregate them into groups, and then we give them individualized therapy, and then we kind of expect a good result. So where does it start and where does it end? That's another question. So it starts off with deep phenotyping. So we get a lot of information. So we already collect medical history, lifestyle, physical exams. Those we usually connect. Then as we go down, we get more and more data. So it could be laboratory data, imaging, functional diagnostics, and then again, genomics, metabolomics, all those things. And we connect it into big data. So we have a lot of data that is there. And then we start going them, moving the data to different tracks. So first track would be pre-processing. So you do data mining. You kind of see what is the variables that are important, what you're looking at. With that, you kind of develop diagnostic and prognostic models. And then subsequently, you kind of predict treatment response. And then this is kind of disseminated and used at the bedside. So this process is like, it's supposed to be more of an evolving precision medicine. So it doesn't stop with one this thing. So initially, like for example, in this example, so we have individuals who have one shared characteristic. We put them into the model and then we look at the outcomes. Then with that, we kind of get more details, and then we keep like amplifying the loop. So with AI coming into the picture, we get more and more refined loops, and we can continue to improved outcomes and even prevention, focus on prevention. So I will be talking about, how to use this BePRECISE checklist. So this is again published in Nature. This is in March of 2024. So what the article says is that there's a lot of research that is coming out. So there's tons of precision medicine research, especially related to translation medicine, clinical research. But however, scaling that to the clinical practice has always been quite difficult. We see a lot of fancy data, but whether it can be used in the bedside, they're always stuck with that. So this article started off with a consensus report. So they said that there was a poor level of standardization amongst all these compared to contemporary standards. So there was no standardization in all these precision medicine uh, uh, articles, and it kind of overlooked underrepresented population. So this again tend to bear the greatest burden. So this is what we commonly see in our journal clubs. We have RCT, that's usually a European population, and at the end we say, oh, can it be applied to our population? We just kind of say yes, probably yes. But probably that is something that can be looked into more in detail here. And this checklist is supposed to be used along with existing guidelines and checklists like CONSORT, STROBE, and PRISMA. Okay, so again, it's complementary, not independent of that. So again, they also give their own definition of precision medicine, which is focusing on minimizing errors and improving accuracy. Okay, and it seeks to maximize efficacy and cost effectiveness, safety and access for those in need, and improve your compliance overall. So here we end up targeting diagnostics, therapeutics for prevention and treatment of subgroups of population who share the same similar characteristics. So whereas personalized medicine is more of using, again, it's like nested within precision medicine where you use the patient's own data objectively to gauge the efficacy and safety of the therapeutics. And along with that, you use the patient's individual preferences, circumstances, and capabilities. The four pillars of precision medicine would be, you have prevention. So most of the studies should kind of fit into either of these. So either prevention should be related to diagnosis, treatment, or prognosis. So let's start with the case scenario like we usually do. So a 25-year-old gentleman comes to you. He has a very strong family history of dilated cardiomyopathy. His grandfather and his father have had the disease. He's a smoker for the last 3 years, leads a sedentary lifestyle, and then mouse, which sorry. That's better. Yeah. So he's been a smoker for 3 years and he leads a sedentary lifestyle, and then comes to you and asks you whether doing a genetic test will predict his outcomes or will he have better outcomes with that test. So I'll be looking critically appraising this article. This is an article that's published in JAMA Cardiology 2 weeks ago, looking at bidirectional risk modulator and modifier variants of DCMI and hypertrophic cardiomyopathy in BAG3. Okay, so the first part of the checklist looks at, so I would have color coded the whole rest of the presentation. So the checklist, everything comes in orange, and the rest of the answers would come in white. Whatever the study is done is in white. So the first thing, the most important thing that they felt was most important was equity. So equity, inclusion, diversity, and patient public involvement. So that's the first thing that they look at. So did they use appropriate descriptors such as ancestry, geographic, and social demographic characteristics? And did they involve underrepresented groups? That's something that they wanted to highlight. So the authors usually encourage them to include all this information in the relevant group subheadings. So looking at the study, it was a cross-sectional study of the Penn Medicine Biobank enrolling patients under the University of Pennsylvania health system, that is from 2014 to 2023. And this looked at many 30,000 patients of European descent and 11,000 patients of African descent. And then they proceeded. So which are the groups that are excluded? So they had excluded a large number of around 582 Latino population, East Asian, and again South Asian 568 individuals they had excluded. So again, this is something that they could have included. So the checklist, what it says is when data from unrepresented groups are collected and the number is more than 20, all data should be analyzed and reported separately. They don't want, even if the number is 568, they want to include that data so that later on it can be used probably as part of a meta-analysis, something like that. So we'll have data available, and we won't be clueless about what to do about if such a patient comes to us. So why is this number 20 less than 20? Because again, you don't want to disclose patient identity if it is less than 20. So that's why they took a cutoff of 20. And they again recommend avoid merging subgroups into larger heterogeneous groups such as non-European ancestry and things like that is what we commonly see. So again, the checklist mentions that race and ethnicity are social constructs, but these are things that are recognized by governments and health bodies and are important, and hence they've included these terms even though they are slightly controversial. So looking at the baseline, again, this is the PMBB base that we're looking at, and predominant, again, European population, and they had around 443,000 individuals. In most genomic studies, candidate GWAS studies, we usually find that there are multiple genes that are associated with a certain disease. And these are usually spurious associations, so they are not actually related to the disease, or there may be some locus that is, there may be some variants that are close to that locus which may actually be responsible. So what they do is usually when we have one study, we kind of replicate it in other databases that we have. So this is the other UK biobank that they use. Another database in this BioVU is the biobank that they had for Vanderbilt University, and MyCode is another large registry that they used. So next question is, what are the implications of inclusion or exclusion of patients who are understudied in the precision medicine research? So this is not being specifically mentioned. So one thing that they could have highlighted is they have included a large number of African individuals of African ancestry. So that again, this is actually the largest data bank in the US, which has around 25%, a large proportion of African individuals. So they could have mentioned that, okay, this is generalizable to that. They did not mention about, okay, they have excluded these people, excluded, for example, Southeast Asians, all those things. So what are the implications? They have not mentioned. However, at the end, they have acknowledged that more studies need to be done in healthcare populations. A little vague term statement they've given at the end. So they could have mentioned these details also. So then the next E3 and E4 are related to patient involvement, participants and involvement. So basically throughout the research from start to finish, how were patients involved in your study? So were there patients on your research team? Were they part of a survey? Was a survey conducted to know their perspectives? Were they any advocacy groups were involved or not? Those were not included. So an important way, an easy way to find out is you look at the acknowledgements. You see if any patient advocacy groups, anything has been involved. So none of them have been involved in this study. So basically it's about recognizing your patient's expertise. Second thing, E4 is related to when looks at patients who have lived experience perspectives. So when the research comes out, how does a person with the disease respond to it? And it also recommends to consider co-writing these aspects. So technically you get a patient, you consider getting a patient who has the disease, and then you co-write how these findings of your study will affect their lives. Okay, so this also has not been taken into consideration. So that's the first main heading. So equity and patient involvement is what they first looked at. Second, so the first thing that after that they come to title and abstract. So they want the title to be as clear as possible. There should be a lot of clarity in this section. So this usually the title is of a study is the first thing that people see. It's like the hook and kind of like without like explaining the whole plot. So you just want to hook people and then so that they're interested in reading the results. And often groundbreaking results get lost because the title is too vague or can't be understood by people who are not a scientist. Okay, so that's something. So the simplest thing is first include precision medicine in the title of the abstract. So have they done that? So yeah, they have not done that. Bidirectional this modulator and modifier variant of dilated and hypertrophic cardiomyopathy. Technically, if I was not given this paper, I would not have read it because it looks too complicated for me to understand. So this is something that has to be used at the bedside. So you would want something that is straightforward. You know that, okay, what this study is trying to look at. So highlight the research that is related to precision medicine. So next question is state the research question. So just like any other this thing, do we have a FICO statement? So again, this looked at all patients of the PMBB biobank and of African European descent, and they had whole exome sequencing linked to that, linked to their electronic health phenotypes. So this is from 2014 to 2023, and they look for exposure. That was the carrier status for this particular gene. So BAG3. So I'll come to why they chose that particular gene later. And the outcomes that looked at was association with clinical diagnosis, echocardiographic traits, and longitudinal outcomes are also assessed. So the object, okay. And subsequently, what is the design of the study? They have mentioned it's a case control study, and then they have replicated in 4 other databases as I mentioned in the baseline characteristics table. So the setting, so this is not explicitly mentioned, they just mentioned that it's a healthcare population-based study. But if you go to another article that they have published on the Penn Medicine Biobank, they mentioned that it was 6 large hospitals and 10 multi-specialty centers that serve South Central Pennsylvania, New Jersey, and Northern Delaware. Okay, so subsequent, the next part of the thing is whether the study relates to prevention, diagnostics. So the 4 pillars: prevention, diagnostics, treatment, and prognostics. So does it clearly say what exactly does it fit into? So here the study mentioned that the objective of the study was to interrogate clinical traits and diseases associated with BAG3 coding variation. So it seems to lie somewhere between diagnostics and probably more in favor of prognostics. So how patients with this particular mutation in DCMY, how will they respond? So that's more in terms of prognostics, but they've not really clearly mentioned that in your abstract or the title. So do they describe the population or the subgroup that is the focus of the current analysis? So again, they have given some characteristics of 43,000 individuals, median age of 65, and equal around 50% of women. Again, mentioned the number of European and African individuals, and they're kind of excluded your 2,209 individuals who have other ancestry. So coming to the second part, which is the background and objectives. So usually in a typical checklist, we always start with the PICO statement first. So here we started equity, then we started about what is the title, was it appropriately set? Then we come to the background and objective. Why did they do the study? So state the study hypothesis describing specific rationale for this precision medicine approach. So the reason why they did it is the reason for reduced penetrance and variable expressivity of heritable dilated cardiomyopathy is unknown. So if just a refresher on in genetics, so complete penetrance is when you have individuals of a particular phenotype, all of them have the disease, they have a specific genotype, all of them have the disease. Whereas incomplete phenotype is, penetrance is when they have the genotype, but not all of them show the disease. Whereas variable expressivity is when they have different variations in the phenotype. So here they have one phenotype, and here they have different. I mean, for example, a patient who has dilated cardiomyopathy or has the gene for dilated cardiomyopathy, all of them may not have DCMI. Some may have just echocardiographic findings, some may have arrhythmias, things like that. So this phenomenon of varying expressibility and penetration not being good is typically been described in this tight-end truncating variance, which is the most common genetic cause for heritable DCMY. So they have found that BAG3 from previous genetic studies plays an important role. So BAG3 does not code for any sarcomeric protein, or it does not code for any cytoskeletal protein. It codes for a ubiquitous cellular protein, and which is kind of responsible for inhibiting apoptosis and kind of maintaining integral structural integrity of the cardiac myocytes. So it kind of helps in during stressful situations. So BAG3 variants have been implicated in prior studies in both DCMY and HCF, and hence this is a potential gene for interest and can probably harbor potential modifier variants in DCM. So state all the study objectives. Okay, so here we're looking at four main things. So one is etiology, discovery, whether it's related to predictive or confirmatory. So etiological, is it describing the heterogeneity across individual level data? Or is it discovery? Is it testing for association and identifying new risk factors? Three, whether it's predicting. So whether it is creating a new tool for doctors to use at the bedside or reproducing data that is already available. So this study particularly involved, I mean, they were looking at heterogeneity in clinical diagnosis and echocardiographic traits. And discovery, they also looked at association with BAG3 and checked if there were different coding variants had different outcomes. So looking at the methods, so this method, again, this is a very broad heading. So they look at methods. So they write, the first question is, describe aspects of the study design that is necessary for the design to be adequately understood. So basically you need to understand, and a person listening to it should be able to, reader should be able to understand and should be able to replicate it. So have they given enough detail? So it's not very, it's a more of a broad point subsection. So to explain that, I mean, you need to know a little bit about genomics and genetic studies. So there are different types of genomic studies. So first is the GWAS study. Okay, so genome-wide association studies, and the other one is phenotype-wide association studies. So here in the GWAS study, we start with the phenotype. So we start with, okay, all individuals who have height. So there are tall individuals, short individuals, and then we look at what are the genes that have been implicated for height. Whereas in the PheWAS study, we kind of already know, okay, these genes are related to height. How do they, what are the different phenotypes? Do they affect height significantly or not significantly? Or are there different variants in the phenotypes that can be there? So what they mention is that they use the genome first approach. So they already found genetic variants of interest, and then they subsequently associated them with phenotypes. So they had this, so medical biobanks are the ideal place to do this because they have the whole exome sequence already with them, and they can connect it with your electronic health records data. And then usually they're looking more for very rare loss of function variants in single genes or targeted genes along with clinical phenotypes. And then they're already also known as P codes, and they kind of uncode relationship between gene and disease. So this is an example. So this is not exactly from that study, but this is from the previous study of Penn Medicine Biobank. So we have whole exome sequencing data, we have electronic health records data, and then we kind of find out which are the genes that are we think might be significant, and we merge them with the P codes, that is the phenotypic presentation that they have. And then they finally find that, okay, there are 97 gene burdens which have a significant P value. Then they subsequently replicate that in other databases. And then we kind of use validation or replicate or you validate it, and then we kind of broadcast it later on. So that's the whole methodology section of how they went about collecting data. So again, there was IRB approval. They underwent whole exome sequencing by Regeneron Genetics Center. So they had excluded samples with a low exome sequencing coverage, more than 5% when there was more of high missingness that was there. And when there was a dissimilarity between the reported sex and the sex that you got on genetic analysis, they of course removed samples who had first and second degree relatedness because you don't want other things getting flagged as genes of interest. So the clinical data, again, patients were determined to have a specific phenotype. If at 2 visits to the hospital, they had a corresponding ICD diagnosis. So you come twice, you have the diagnosis of hypertension, then you're taken in as a specific belonging to that fee code. And again, this fee codes, they had mentioned the statistical model. They had used a logistic regression model, like Sir mentioned, and they had adjusted for age, genetically determined sex, and principal components of genetic ancestry. So this principal component analysis is a statistical method that is used to prevent population stratification bias from coming in. So PWAS approach, again, was further used. So they finally found the gene, and then they used this thing to look at other phenotypes linked to variants associated with DCMY, and they conducted in both ancestry. So what is the rationale for why they chose these outcomes? It's not specifically mentioned. The outcomes they looked at was clinical diagnosis, which is important. Echocardiographic traits may be useful for a physician, may not be for a patient. Again, survival analysis. This is interesting because even though it is a cross-section study, they have looked at, they have some sort of follow-up period also. And they also looked at survival analysis, which again is quite clinically relevant. So how did they, so if the database, so next section is, if the database is a subset of a larger study, how did they include these patients? So how did they include patients into the biobank itself? They had face-to-face encounters. That is before COVID, they had face-to-face encounters with someone other than the treating team. So they had clinical research coordinators in OPD, lab areas, blood collection areas, patients undergoing catheterization suites. All these places you would go, and then once COVID hit in, there was remote efforts to involve patients through e-consent and using enrollment through RedCat. So the exclusion, they have kind of included whoever was consenting and whoever was above the age of 18. So they also on their website, they have kind of a very nice video also which says that how the blood that they're giving would contribute to scientific research, and it's purely altruistic. And it clearly mentions that their medical care will not be affected if they refuse. And then subsequently, we know that the subset that they chose were those of either European or African ancestry. So the next part of the study is define any markers that is used for stratification or prediction of outcomes in the individual groups. So this upfront, they had not thought of it in the methodology section, but as they went along with the study, they identified 12 low frequency and common coding variants in the gene of interest, that is BAG3, and found one variant that was significantly associated with DCMY. Okay, so this is from supplementary analysis. So they found that this mutation where cytosine is replaced instead of thymidine, it's a missense mutation, and it's termed the C151R mutation, was found to have very significant p-value. Okay, so they used that missense variant was used for stratification based on whether you had carrier status, that is heterozygous, or you were homozygous. So they use this further down the line to stratify their population. So then 3.5 is related to, okay, how reliable are the results? Did they do a sample size calculation? Did they adjust for type 1, type 2 error? So again, they had included patients who had, so specific phenotypes for the disease, at least 20 cases should have been included. And then to say that this person belongs to a specific P code. So from that, they had kind of found 1,396 total P codes. And so as we know, if we have large amount of variables, we need to kind of adjust for that. So they use the Bonferroni correction. So statistical, usually we say p-value of less than 0.05 is significant. They divided that by the number of variables that they had, and they found that the p-value had to be 3.58 into 10 raised to power minus 5 to be significant. Okay. And again, principal component analysis was used, and it's especially useful, especially when individuals coming from the US who have kind of mixed ancestry. So this was, I mean, how did they calculate sample size? This is from genomic studies that are there. Sorry, this is. Yeah, so this is from a Jiva study. This is basically theoretical practical concerns that published in Nature. So like, as you, for example, if you think that the odds of a gene affecting an outcome is around 2, then you need a lower sample size. But as the odds sample size. And again, at the extremes also, the goes up. So this is what they use when they're calculating sample size for a Jiva study. But for a FIVA study, again, this is probably using statistical models is what they use. But they have not really mentioned formally how they came to that sample size. Probably it's a registry already. So they just use whatever data that they had available. So then subsequently, the next part is did they use any approach for internal replication or validation of the study? So replication analysis is those that seek to directly replicate your primary analysis, whereas validation analysis is those that seek to generate results using other slightly different methods, but strengthen the conclusions of the primary research. So here again, like I mentioned earlier, external replication was used using the UK Biobank, the BioVU, MyCode, and this case control study, which is the DCMY, precision medicine study, and all of them had their individual IRB approval. Whether this is predetermined or not is not mentioned, but clearly it appears to be after the conclusion of the primary results because they've looked for that specific C151R variant and how it affects patients. So specify how the sample size for any replication validation study. Again, this is a registry, so they are not really looked at what is the sample size. We know that, okay, the total number of UK biobank people are around 469,000 patients. BioView 64,000, MyCode 175,000, and of which around 3,000, 7%, 0.7%. So the prevalence in the UK biobank is quite less, and then 4.6% and 3.2% had cardiomyopathy. Sure. So the next question is specify how okay, sorry, the same thing. So again, DCMY precision medicine, they also use this Perth penalized logistic regression. When we have smaller sample size, it kind of gives a penalty. So it kind of reduced bias. I think Sir may explain that better. The other thing is, in the end, they had come with cases that was around 960 cases out of 12,000 probands. And controls was 1,200 probands, and controls 618 out of 2,406 controls. So again, this is just showing how the DCMY study was conducted and how they had excluded people who had other ancestry, those who did not have adequate genomic data that is available, or inclusion criteria was not met. So just, I mean, this is not part of the checklist, but just like how we do for other checklists. So how valid are the results? How valid was the study? So equity, so here the focus is more on equity and patient participation, like I mentioned. So equity definitely could have been better. They had included African individuals, like African ancestry. They could have included South Asian, other ancestries as well. Again, patient involvement was poor. The title could have easily mentioned precision medicine. They could have had more clarity on the objectives. So whether it was exploratory in nature, what exactly did they mean? No sample size calculation was there. Then they had mentioned that they had done a Bonferroni adjustment for the p-value. And again, they have done a replication study. And with most genetic studies, very important is the quality control. So quality control should be high. And these biobanks seem to have that high quality control. So coming to the results, again, the same table again. So this, have they mentioned, have they mentioned the number of participants in each analysis and provided baseline characteristics? So again, this we have gone through already. We know that the most common P code was cardiac dysarrhythmias in 29%. Then subsequently, those with heart failure 15% and those with heart valve disorder. And primary cardiomyopathies again only 7%. The UK biobanks only 0.7%, so it's quite less. Next is what are the results? So have they mentioned the results and have they used mentioned any of the statistical tests that they have included in finding those tests? And what are the results from subgroup comparisons? So here's, this is similar to a Manhattan plot, but it's not exactly a Manhattan plot. Manhattan plot would have your chromosomes from 1 to 22. Here they're looking at different P codes. So those with infection diseases, neoplasm, so that's on the x-axis. So they have different P codes on this side. And here they're looking at our gene of interest, so BAG3, and they're looking at the particular missing variant, that is C151R. And they're looking at what all conditions were found to be significant. So if the triangle, if you all can see, the triangle is facing upwards, it means an increased odds. The triangle is pointing downwards, it means a decreased odds. And they have two dotted lines here on the y-axis. So this is our traditional p-value of 0.5 that we take. And this is the p-value that they found based on their adjustment, which is 10 raised to power minus 9. So of all the diseases or the phenocodes, we found that cardiomyopathy seems to be negatively related, has a negative, has a kind of a protective odds ratio is what it shows. And so what they did is, again, they have mentioned that it is a logistic regression model that was adjusted. This again in the method section. And then they had analyzed the group separately and then kind of combined the results with inverse variance weighted meta-analysis. So again, these are all the significant associations that they found. So they had found quite a few. So this is all 10 raised to power, p-values 10 raised to minus 4, all these things. But the only one that fits the adjustment seems to be cardiomyopathy. So then they go on to, okay, if you had a single allele, what is the risk? So what they found is, if you had a allele for DCMY, it decreased the risk. So the odds ratio is 0.85, so 15% and less risk. And if you had, however, at the same time, you had an increased risk. So you had a decreased risk for dilated cardiomyopathy, but had an increased risk for HOCM and other HCM, hypertrophic cardiomyopathy. So the odds ratio goes up to 1.69 and then subsequently 1.61. So this, again, if you remember the Bradford Hill, so this is kind of showing like a dose-dependent response. So the wild type, which is the common type that we see here, they have, DY incidence is, sorry, HCM incidence is low. And progress shows that it kind of, as you have a heterogeneous, you have one allele, it kind of goes up, and then if you have both alleles, it goes up further. Whereas maybe the same may not be applicable for DCMI because both heterozygous and homozygous seem to be kind of similar. Again, echo findings, they have given very complicated echo plot, but again, they have kind of mentioned that consistent with decreased risk. So some of the values that may be interesting or important to cardiologists, like decreased LV systolic diastolic diameter, seem to be low risk, whereas high risk. But again, how much is clinically relevant in this? I'm not really sure. And from when I looked at this table, it looked like more of the numbers are all quite similar. So I couldn't really find any difference. So then association with longitudinal outcomes. So even though this was technically a cross-sectional study, they had all the data for when the patient died, when they had a cardiac transplant, and they kind of plotted that as well. So they assumed all patients who had started off with a risk at the age of 20 years, and they kind of plotted when they would die and kind of made a Kaplan-Meier curve. And overall, it looks like, they have mentioned here that the odds age at death shows that there was a significant decreased risk of death if you had that mutation, and even decreased risk of, the time to event for age of heart transplant and age of death is less for those who had that specific genetic mutation. But if you look at the graph, it seems more or less like all of them are overlapping. So here, even they have compared heterogeneous and homogeneous allele carriers, and that's also kind of seems to be overlapping. So then coming to the most common variant that we know of dilated cardiomyopathy, which is the tightened truncated variant. So they assess for this as well. So one, they looked at the gene per se, the tightened gene, and they found that it was associated with increased risk of DCMI. This we already know from multiple other studies. How does our gene of interest relate to patients with this mutation? So they found that patients who had this specific C151R was associated with decreased risk of congestive heart failure amongst this group. So they had a significantly decreased odds ratio of 0.27, even though the confidence interval is slightly wide, 0.14 to 0.5. Again, however, this is not replicated in the UK Biobank data. So again, once you have all this data, okay, how are you going to benchmark this against current practice? Are you going to include this in an algorithm? Did they do that in patients for patients who are presenting to the hospital with DCMY? They have not really done that. Then the next part of the checklist is, have they provided results for all attempted validation and or replication analysis? So again, the same data, the same results that we found, they run it through the UK Biobank, BioView. So again, I already mentioned that the prevalence is quite less in the UK Biobank, and the BioView and the UK Biobank kind of show similar findings. So it shows that if you have the genetic variant of interest, there's a decreased risk of DCMY and again an increased risk of HCM, and it kind of shows a dose-dependent response for these two databases. However, for MyCode MyCode, it doesn't really show that it's not statistically significant. It shows that there is a decreased risk in dilated cardiomyopathy. However, there is the increased risk for hypertrophic cardiomyopathy that you can see that the confidence interval crosses 1. So it's not statistically significant in this data set. Again, the DCMY precision study, though point estimates indicated that there is a lower DCM risk, again, it was not statistically significant. So two data sets kind of showed that it was replicated the initial result, but these two did not. So coming to the last part of the checklist, which is the discussion. So has the checklist given a balanced and nuanced view of any limitation that is there? So they have clearly mentioned that they had limited power to assess dose-dependent associations. They had looked at only the specific BAG3, and in that they had looked at C151R mutation. And kind of suggests that, even though we know that C151R is related to DCM penetrance, what is the exact mechanism? Again, we don't know. Maybe we need to do further studies. So these are limitations that the study has said. They have not, of course, mentioned about other things like cost effectiveness, how will it be applicable to day-to-day life. Those things are not being mentioned. So the last part of the checklist is 5.2, which is, now that we have this data, how can you potentially apply it to clinical practice? That's what you're looking at. So can it be included? So what the study writer said is it can be included in panel testing. So in patients with this truncated mutation, and kind of know, okay, these patients are at less risk for developing heart failure. These are patients who are at higher risk for developing heart failure. Other one, this is a new step because we don't technically see DCM and we look at them as distinct entities. We don't look at them as a spectrum. So here it kind of shows that, okay, they're all different, I mean, on the same spectrum, and based on what genetic background that you have, you may have either DCM or you may have HCM or some varying phenotype in between. And again, there has been some animal models that have been done showing that if you decrease the BAG3, there may be improvement in LVEF function. So again, this is a long way to go. Again, so the checklist clearly mentions that they are not mentioned about cost effectiveness. They felt that doing an analysis on that per se is going to be complex, and they may revisit this in subsequent versions of the checklist. So coming back to our patient, what would you do next? So based on this study, again, we have clearly know that we have excluded patients of South Asian population. So we would not recommend to really check for these variants per se. Perhaps if we had done another study in Indian population or in all Indians, we may have a different result. So this is again just taken for up to date. So genetic testing for familial dilated cardiomyopathy. Actually, the American guidelines, heart failure guidelines, kind of say that okay, we should do genetic testing. Again, whether in our setting, it may not be very applicable due to cost and availability concerns. Thank you so much.